Fakultas Kedokteran, Unair tercinta, jadi kebanggaan Indonesia. Pelopor pengembangan pengetahuan, inovasi, adaptif kolaborasi.
Kita mencintai Unair, hati kan empati, pusat pendidikan terkemuka, world class medicine faculty. Fakultas Kedokteran, Unair tercinta, jiwa wirausaha, akhlak mulia, profesional, responsif, inovatif, modern dan bangun entrepreneurship. Kita mencintai Unair, hati kan empati, tanggung jawab, disiplinkan diri, the prime medicine faculty. Kita Unair, kita mencintai Unair, hati kan empati, tanggung jawab, disiplinkan diri, the prime medicine faculty, the prime medicine faculty.
Hi, Mahendra.
Hello, Professor Bose. Thank you for joining with us. The video is still black, but I can hear your voice very clear.
Good evening, ladies and gentlemen. Welcome to the 18th Airlangga webinar conference series with the topic of role of music therapy and nutrition for optimizing quality of life in preterm infants. My name is Kevin, and along with my senior, Dr. Ahmad Heriana, pediatrician, and my colleagues, Dr. Sacha, Dr. Kenneth, Dr. Eko, David, Rahul, Win, and Arya, we are the organizing committee members of this evening's webinar. This webinar is organized by the Faculty of Medicine, Universitas Airlangga, Surabaya, and we are happy to announce you that up until now, the registrants have reached 258 participants. And before we proceed to the main event, we will announce some of the rules regarding the certification and Q&A session of this webinar. Okay, the first is rules for certification. Full participation during the webinar is required. Your attendance will be recorded by the Zoom application, and by the end of this webinar, participants are required to fill a questionnaire which the committee will send the link in the chat box. And lastly, the certificate will be sent to your registered email address. Next is rules for Q&A. You can use the Q&A box on the middle of your Zoom panel to write down your questions. Questions then will be sorted and discussed after all lectures have been presented. Thank you all for your participation, and we sincerely hope you enjoy this evening's webinar. We will start this event with an opening remark from our beloved host and moderator, Dr. Martono Triutomo, pediatrician and neonatologist. To Dr. Martono, the time is yours.
Okay, thank you, Dr. Please, Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen. Good afternoon from Prof. Aaron Bos and Prof. Sauer. It's an honor to have you as a speaker in this webinar. I also hello to the Honorable of the Chief of State Department, Dr. Sutomo Academic General Hospital, Dr. Muhammad Faisi, and thanks for the panelists, Prof. Dr. Rinawati Rosis Patmo, pediatric consultant from the Cipto Mangunkusumo Hospital, Dr. Setia Dewi Lisyati from the Harapan Kita Hospital, and from Dr. Risa Etika, pediatrician from Dr. Sutomo Hospital. And before I start the webinar, maybe we can hear some of the Indonesia Raya song. This from the team of the AWCS.
Di sanalah aku berdiri, jadi pandu ibuku. Indonesia kebangsaanku, bangsa dan tanah air. Marilah kita bersatu, Indonesia bersatu.
Hiduplah tanahku, hiduplah negeriku, bangsaku, rakyatku semuanya. Bangunlah jiwanya, bangunlah badannya untuk Indonesia Raya. Indonesia Raya, merdeka, merdeka, tanahku
Okay, thank you about the song. It's very grateful song. The next we invite Dr. Faisi as the Chief of that Department, Dr. Stomo Academic General Hospital, to give a speaker, to speak. First, the time is yours, Dr. Faisi.
Thank you, Dr. Martono. Can you hear my voice, audience?
Yes, Doctor.
Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Good evening in Indonesia. Good afternoon in Netherlands. The honorable speakers, Professor Arenbals and Professor Peter Sauer from University of Medical Center Groningen, the Netherlands. To all panelists, Professor Dr. Rinawati Rosiswanto, Pediatric Consultant, Dr. Setia Dewi Lusiati, Pediatric Consultant, PhD, and Dr. Risa Etika, Pediatric Consultant. To the moderators, Dr. Martono, Pediatric Consultant, and to committee, Dr. Mahendra, Dr. Asra, and AWCS team, and all the participants. First of all, I would like to thank you to the merciful Allah who gives us the chance to gather in this Zoom meeting. I'm Muhammad Faizi, as the head of Department of Child Health Faculty of Medicine, Universitas Airlangga. So happy to meet you all, the physician and the students that already provide the time to join these webinars, even in this COVID-19 pandemic. I hope all of you still have passion in research and science to improve the care. As we know, the goal to increase survival rate of premature infants still not achieved until now. The preterm babies are susceptible to environment due to immaturation and several origins. Painful treatment in the newborn intensive care unit and ICU can potentially lead to poor social emotional outcome of neonatus. As a result, non-pharmacological therapy and individual development care strategies have risen to help preterm infant and their carers cope with traumatic event. This webinar is held by Faculty of Medicine, Universitas Airlangga, as an outcome of adjunct professor of Professor Arenbos with Airlangga webinar conference series. Thank you, Professor Arenbos and Professor Peter Sauer that give the opportunity to us to learn about several steps that can increase the quality of life for the babies. The topic of this seminar is about the music therapy. So I hope our webinars can give us better understanding about the efficacy of music therapy and nutrition to reducing the stress of preterm babies and improve the outcome. I hope you can enjoy the presentation. Thank you for all participants for your attention and good afternoon. Thank you. That's all.
Okay, thank you, Dr. Faisi. Now we can begin the presentation. First is our speaker is Prof. Aaron Frederick Bosch. He is a professor of the pediatric neonatology and head of division neonatology in the pediatric hospital. The education is from very much the working experience and maybe more than 400 publication, and the citation is 10,000 citation. For the Prof. Boss will present the topic of about role of music therapy for preterm infant, and you have the 35 minutes for the presentation. Please, the time is yours, Prof. Boss. Please, still mute, Prof.
I'm sorry, Professor. We cannot hear you.
Can you hear me now? Yes?
Yes,
Okay.
Prof.
Yes, Prof.
Thank
Okay.
you.
Then I start to share my screen again. And this is the first slide. Can you see this first slide, or should I change the?
Yes, Prof.
Okay, thank you. So my talk is about a new development in neonatal intensive care, which we have done in the last 2 or 3 years, and it's about music therapy in the neonatal intensive care. And that's one of the innovations we encountered. And I will share with you what we did so far and the background of it. So first of all, I don't have anything to disclose.
Ari, can you please make a slideshow, please?
Ini loh minum, sampai camil-camil.
Sorry. Is it now okay? Do you see my first slide? Mahendra? Second slide, no
Okay.
disclosures?
Okay.
Not slideshow. This is what we call it. It should be more. It should be bigger than this one. So this is not the slideshow we meant.
Is this better?
Yeah, this one is better.
Okay. So thank you. Sorry for the technical mess up for this meeting, sorry. Okay, what I want to discuss with you is a little bit about the introduction on music therapy as a new development, a little bit about the evidence, what known and what not, and how we provide it in the last few years in the NICU, how we proceeded, and also some preliminary results on research we have done on music therapy. So why is this important? Well, what we know from the future, from studies in the past, and this is already done in 2008, is that with a lower gestational age, going to 24, 26 weeks, the intelligence measured here with the Kaufman AWCS is declining. So from about 34 weeks onwards, every week lower gestational age, the intelligence is lower until about 2 standard deviations, 1 to 2 standard deviations below the norm. So that is strange, and why is that so? And we also found that similar as in these studies in our follow-up in our NICU, that, for example, total IQ has a mean IQ of 92. It is normally distributed, more or less, and well, normal is the 100, so it's about 8 points lower, and that means actually half a standard deviation lower than the norm. So there's probably something going on in all preterm infants, that shift of the normal curve for example, intelligence is shifted to the left, and the same is true for movement ABC, for the motor skills. It's also even more pronounced, more than one standard deviation, but more or less distributed. So that means that all preterm infants are more or less affected, and that gestational age is an important determinant. So why is this so? Why is it that all these babies have problems? And it might have to do with the preterm birth and brain growth and differentiation, for example, disturbed by inflammatory processes or by oxygen or by a lack of nutrients or disbalance in nutrients. But it could also be because it's still the same as in all these years where we have improved the upper things. It might also be that it's unusual stimuli. So, for example, light and noise and touch and stress and pain. It's another environment, and the stress and pain is much more into intention the last 5 to 10 years as a cause of these problems. And as our in the neonatology in our department, we have a vision and a mission. We provide intensive care to newborn infants, which are sometimes very vulnerable and tiny children. And our aim is to have a healthy aging as possible. So healthy survival is our main goal. And we should do that as non-invasively as possible. It could be very intensive care, and it's teamwork with doctors, nurses, and parents. So if stress and pain is in stake, why we are looking for several interventions. And in adult intensive care, music therapy has come up as an intervention. And here's an example of a slide from the United States where they play in the intensive care music, live performed music therapy. And so we came across that in approximately 2.5 years ago, when I was invited to give a lecture in Enschede. It's only one place in the Netherlands. It's in the east of the Netherlands, where they have a school for music therapy. And I was asked to give a lecture about neonatology. And first I thought, well, what could that be? Perhaps it's music therapy for ex-preterm infants, but no, when they are at school age. But they actually, the group that had this symposium organized, they came from New York City and played in the intensive care for the babies. And it was very interesting. And I said, well, we can have that here. So I looked at the evidence, how much has been published about music therapy in the neonates. And it's only in 2018, in 5 years, it's only 47 hits in PubMed. But now, a few months ago, in September 2021, it's already nearly 270 hits. And there have also been several meta-analyses been published. And the last one is from very recent in Acta Pediatrica from Mohan and colleagues, where they said that it's a very low quality of the evidence and a very heterogeneity of studies. But there is some evidence, and I want to share that with you first. So this is the evidence, for example, on heart rate and respiratory rate. And these are so-called forest plots, where you can have the separate studies here on the left for heart rate, and you see the number of infants included in the experimental and in the control group. And then you can see here the effect size, which favors on the left side music therapy and standard care on the right side. So some studies have good effect, some others opposite effect. And combined together, you can have an idea about the evidence on music therapy. And here it's on heart rate. It gives that it favors music therapy on heart rate. You become more quiet. Same as for respiratory rate. It's still not going 100%, but that's how these forest plots work. So there's evidence that it has a good effect on physiological parameters such as heart rate and respiratory rate. What about behavioral state? It also, there's not so many studies, but it also favors the behavioral state, music therapy, and behavioral distress, but only 2 studies and only very limited numbers. 42 infants studied versus of 84 studied in between controls and music therapy, but it seems a good effect. And finally, there might also be influence on growth, weight gain, and now it favors music therapy here, but also not so many studies. Perhaps better weight gain, time to oral feeds, perhaps less, and a very large effect, only 3 studies, but a very large effect on maternal anxiety done with questionnaires. So there is several meta-analyses that have good effects on short-term physiology. It reduces anxiety in mothers and potential effects also on feeding and growth. And what also came out of these studies is that live performed music is better than playing recorded music. So from a band or a CD, live music is better. So what is unknown is what are long-term effects of these developmental effects of this music therapy. And is there also groups that benefit, and when? Is it the first days and the youngest NICU children? There's nothing known. Several years ago. Are there perhaps cultural differences? It might be different in Indonesia or in Netherlands or in Italy or in the United States. And there's also, how can we practice? How do we do that? Is that individually? How often and how long? And is it in a Dutch setting, is it feasible? What do parents think and what do the healthcare workers think about music therapy? So there are quite a lot of unknown things to explore. And there are also possible approaches to music therapy. You can have a rhythmic approach, and this is all taught by the music therapy school in Enschede, but also in New York City. It can be rhythmic, where you follow the respiration and the heart rate, and first take the tempo of the baby, but then slow down, and then respiration and heart rate also might slow down. You can provide melodic song or an ocean board, which I will come back to later what it is, and so give structure to crying. You can have a melodic guitar playing with quiet tempo and soft. And of course, there are also songs parents sing for their babies. That's very common. The Song of Kin, that's actually the family songs that are lullaby-like, that can be provided. And finally, you can have a group where you integrate the NICU sounds, the beeps, and improvise with the group and offering structure to the noises. We chose for the ocean board and the guitar. These are the instruments that are used. The gata box is just where you can provide the rhythm. Ocean board is some kind of a tambourine where you have metal bullets in it, and when you move this board a little bit, then the metal bullets start to move, and it looks like it sounds like an ocean. And we provide it in the youngest infants. And guitar is, of course, well known that you can provide song. So how did we proceed? We started in September to give live performance music therapy, to offer it to the babies. And we did it 3 days a week. We had a music therapist for 16 hours a week. And we offered it in all NICU infants above 30 weeks because there the evidence was there that it if it had effects, it were positive effects. Of course, we have parental consent, and it's part of our standard care. And we also performed a pilot study where we looked at the feasibility. Could we provide music therapy on the NICU to the youngest infants born below 30 weeks, where we also investigated safety and of course, the feasibility in a randomized controlled trial, and it's a crossover design, which means that we asked the parents if they would approve for the study. If so, we randomized the infants to either 2 weeks of live performed music therapy, and the other group was put in the control group, standard care, and after 2 weeks we changed. So then the group that had live music therapy was in the waiting list, and waiting list group had provided music therapy, but after 2 weeks. And we did that in this way to study, of course, but also because we had only had one 16-hour-a-week music therapist, and we could not provide it to all babies. And this was a way to give all babies music therapy at least 2 weeks in the first 4 weeks of their life. And we evaluated the short-term effects so far, both in the standard care group and in the randomized pilot study. And how did we provide? Well, we provided the ocean board with the metal bullets in it and the guitar. And the guitar that was with singing, and then often the Song of King. And here is a picture how it is done. This is a larger baby, not a preterm, where the music therapist provides the music therapy. The parents are present if possible and can hold the baby, and she is doing the music therapy. We looked, of course, to the safety issues. We looked at experiences of parents and nurses. We looked at the general movements and about the oxygen content with NIRS in tissue, and we had questionnaires for maternal anxiety. And I will go into detail in the next 10 minutes or so. So first, the safety issues, because in the tiniest infants, we were, of course, curious if they were not overstimulated by the music. They're sometimes very young, 24, 25 weeks, 600-700 gram babies. So here is what we used as an instrument, the NEO comfort score. So that's a score the nurses apply, but also the music therapist can apply to all babies. And a score of 14 or higher is more or less that the infant is in distress, and the lower score is good. This NEO comfort score consists of physiological parameters, but also behavioral signs of the child shows, hands in fist and so on. So that is a validated score list, which we use in our unit. All nurses are trained. We use it for babies to see if they have pain or stress. So before music therapy, it's quite good. And we saw no changes actually after music therapy, even and during and after. There were a few babies already before 14, above 14, but there were also the same during music therapy and after. So we conclude there is, in these 18 infants, we did not overstimulate the babies. The parents were also very positive. Of the 19 parents, we asked for permission in the first. We had the permission from our MATC, from our ethical committee, to investigate 20 infants for our 15 to 20 infants for our feasibility study. And one of the goals was how many parents would decline. Only one declined consent due to fear of overstimulation. And we had no dropouts during the study. And in general, all parents were very positive. What did the nurses score? We asked them about the noisy environment. We have still a unit where 8 to 12 babies can be in one room, so it could be quite noisy. And before, more noisy is here, and quiet is 5 for 5. Before it was very noisy, but then during it became quiet, and it also remained after the session. So the nurses had a good positive feeling about the noise it was less in our unit. So what about the general movements? Of course, that is my experience, and it is a measure of how babies, how the brain of babies do. And you can divide it into a score of normal, but it could also be monotonous, poor repertoire, or even stiff, and all movements start and relax together, cramp synchronized, which is a very abnormal movement pattern. But in addition, we can also look at detailed scores, and we can look at neck and trunk separately, and upper and lower extremities separately, and give a score if it's good, amplitude or speed, or there's range, rotatory components. If it's good, it gives 2 points, and if it's limited 1 or even more, then you only give 0 points. And with this detailed score, you can give some kinds of a quantitative amount, with a maximum of 42 and a minimum of around 5. And the higher the score, the better the infant performs. And the lower and the worse it performs. So we applied that before and after. So we made a video recording of approximately 30 minutes before music therapy. We did it not only in the pilot, but in all infants, also the older ones. In 12 infants, we had 16 sessions, for example, here. And we applied this, the optimality score, the GMOS, General Movement Optimality Score, before and after. And you can see that nearly all infants go up, only 2 declined. So in these this small group, we can see that music therapy improves at least motor optimality score. And is it then that the youngest infants or the oldest infants have this decline? No, well, here you can see before and after, but mostly then the ones that is declining there's one here and there's one here. So it's not the youngest infants or the oldest infants. And when you look at postmenstrual age, it's also not the youngest infants. There's one here and there's one here. So around 31, 32 weeks, it's not the youngest infants that have these problems. So we are, perhaps it does something about the neurological state of the infant. Next, we looked also at near-infrared spectroscopy at oxygen content in brain. We can do that with a sensor, also a very non-invasive approach, where you can put it's applied here in this baby, where you can have a light source with two detectors, and because light goes through tissue, you can have an influence about this saturation. How does it work? Well, the light source goes through the brain. I'm sorry, there's a helicopter now landing, so I close my window. So I hope I can still be heard by you, because it might be very much noise. Because light is going through tissue and it is detected by 2 sensors, the deeper part is actually what is measured. And because oxygenated hemoglobin has another absorption spectrum than deoxygenated hemoglobin, you can measure with this near-infrared spectrum how much is oxygenated and deoxygenated, and you have some kind of a ratio, and then you get tissue saturation. And that means that it is, you measure actually the balance between the oxygen supply to the brain and oxygen consumption of the brain. So what is going to the brain and what is used by the brain. It's a sort of hemodynamic measure. We use it a lot in our unit, and it gives an idea about the circulation towards the brain or towards other organs, whatever you measure. And it's not the absolute value, but also especially the trend, which is important. And we applied clinically because it provides a continuous estimate of brain oxygenation, and you may be warned at early stages of problems. It also responds well to medical interventions. When you have, for example, a low hemoglobin and you see that it's that the NIRS values are quite low, you give a transfusion and then it's higher. It also correlates with developmental outcome, especially the NIRS values in the first week. So what we did in this music therapy, and this was done in the pilot in the very young infants, we had 20 infants and 44 sessions where the NIRS was measured. It were very young infants with median 27 weeks and 880 grams. Not so young sometimes, 25 days, and the post-menstrual age around 30 weeks. And the ocean disc was applied in approximately half, a little bit more, and the guitar and the Song of Kin in 44%. And what we saw were two patterns. In some we saw before music therapy, then during music therapy, that the NIR saturation increased and the saturation of the brain, and then sometimes afterwards too. And it was in 20 of the 44 sessions. And in 24, a little bit more than half, it decreased from before. So this was interesting. And what we also saw that was in sometimes that there were less desaturation. So here you see an infant that had a lot of desaturations before music therapy, during nothing, and a little bit lower after music therapy, but also not so many desaturations anymore. We saw it several times. We did not statistically look at it. So finally, about maternal anxiety, what did we find there? Well, we did again in our pilot, the music therapy below 30 weeks. And we asked the parents to have a questionnaire filled in at start of the trial. So approximately the children were 1 week old. And we asked them to fill in the questionnaire about the state and trait anxiety. That gives a little bit about the trait or the state anxiety is about how you feel at the moment. The circumstances, the trait is more or less your character, if you are more an optimistic person or a pessimistic person, more or less. So the state anxiety is the most important. And we provided it after the 2 weeks again, and some were in the live performed music therapy and some in the waiting list. And here is the dotted line where the cutoff score is for the norm population. So when you have a higher score on this questionnaire, you have more of more anxiety than the norm score. But in the music therapy, you could see that it decreased quite a lot. And in the waiting list, 2 weeks of waiting list, that was not. And regarding trait anxiety, there were no differences, but you would also not have expected it. So this was nearly significant. So already after 2 weeks, the effect on maternal anxiety. So what can we conclude? Well, it seems a promising intervention, live performed music therapy, also in the tiniest infants. And we saw that also the general movement optimality scores improved. And that could be a good sign of their neurological state also for perhaps the future. But we also said that we saw changes in the oxygenation of the brain during and following, and that might be relevant for the brain perfusion. And we still have to look at that in more detail to understand what's happening. It could be both good if they rise or if they fall. And what we saw was already after 2 weeks, a reduction of maternal anxiety. So very fast. And I want to close that we are continuing, of course, with our studies. and acknowledge the School of Music Therapy in Enschede in the Netherlands, but also the collaboration we have with the Louis Armstrong Center in New York City, and all the students that are involved. And at present, one of the PhD students, Hanneke van Dokkum, is doing research studies in this New York City in this Louis Armstrong Center. So thank you for your attention.
Okay, thank you for Prof. Aaron Bos. This is a nice presentation. Thank you for the sharing of your presentation. Now we can move to the second speaker, Prof. Peter J.C. Schauer. He is a professor in the Pediatric Department of Pediatrics Children's Hospital, University Medical Center, Lijn Groningen, Netherlands. Is the head of division of the Neonatology, Erasmus University Rotterdam, and the chairman of the Pediatric University Medical Center, Groningen. Now it's time for the presentation. It's the 35 minutes. The time is yours. Please talk, Prof. Schauer.
I'll try to get a full screen, but that is a little bit difficult for me. How to do that? Because it is below the
Professor, maybe you can click the button in the near the zoom in and zoom out in the bottom right.
Right. Now, first of all, I thank the organizers of this nice meeting for inviting me to talk to you from Groningen. And first, let me express my sympathy with those victims that are due to the earthquake and volcano eruption in your beautiful island, Java. I very feel sympathy with the victims. Can you see my whole screen? I cannot see my whole screen, but I hope you do. Talking about nutrition, we should really start with talking about nutrition before even the pregnancy starts. Because we know that when we give folic acid to a mother who wants to become pregnant, it will prevent the development of spina bifida. And we know that when we give DHA, one of the PUFA fatty acids, during pregnancy, it will prolong pregnancy. And for the talk of today, very important, it might prevent preterm birth. So nutrition starts already before you are existing even as a fetus. Well, let us take a step back. When did the care for low birth infants start in the world? That was in 1895, more than 100 years ago. Then an obstetrician in Paris started with saying we have to prevent hypothermia, we have to prevent infection, and we have to give adequate nutrition at the low birth weight infants. And that time they did not make any distinction between preterm and small for gestational age. All was low birth weight. But these three things are still valid up to today. Here's a part of a picture of that time. In the back you see a box. That was an incubator where they kept the children. And in the front you see a nurse preparing food for the preterm or the low birth weight infant. Then, 1945, Silverman started the care of very low birth infants in the USA. And there's a very well-known story that with many efforts and all new therapies, he rescued a 1,000-gram baby. But when that baby was discharged from the unit, went to home in New York, it was bitten to death by a rat. Then, for me, an important study was done in 1975. Till that time, preterm infants did not receive any fluid or food in the first 3 days of life, because it was thought that they could not tolerate it, and they were overhydrated. And that was the reason not to give any fluid or nutrition. But then one of my teachers, Professor Swire in Toronto, did a study where he showed that the incidence of apnea or prematurity was lower in infants receiving both glucose and amino acids compared to glucose alone. So this is basically the first study showing that nutrition can improve the immediate outcome of newborn infants. The next important step was done by Lucas in London, where he showed that neurodevelopment in boys, not in girls, who received either mother's own milk or preterm formula was better compared to infants who received a term formula. So he showed that outcome can be influenced by the feeding given to the infant. He also found that growth of preterm infants fed mother's own milk was lower, was less, compared to infants fed the preterm formula. So preterm formula at that time, we thought might be even better than mother's own milk. So why is neonatal nutrition so important? Neonatal nutrition is important because two reasons, short term and long term. In short term, it improves the chance to survive and to survive intact with less diseases, less BPD, less RP, and less chance to develop a sepsis. The long-term outcome is that psychomotor development is better when you are well fed in the newborn period. Lower chance of hypertension, lower cardiovascular disease, and lower chance of type 2 diabetes. So it is giving, oh, I have to click. Excuse me, my phone is running. And I cannot stop it. No. Excuse me for this. I'm sorry, I don't know how to stop my phone. No. When we look at the brain of a 25-weeker and we see the brain of a term infant, you see the very fast the very fast development of the brain. And all those changes must be supported by good nutrition. A study done in 2011 showed that when you are sick, your outcome is worse due to continuous infection, stress, that all gives a bad outcome for your brain. And the risk to have an adverse outcome is less when you have good nutrition, good energy intake during the first week of life. So one of the outcomes that nutrition is improving outcome. Here, I'm afraid you don't see it well. And there's something wrong with my computer. But what is shown here is that the chance to have bad neurodevelopmental outcome is lower when your weight gain is higher. So the higher the weight gain in the preterm in the first weeks after life, the lower the risk of a low developmental outcome. So the nutrition is influencing developmental outcome. And we can influence that by giving arachidonic acid, by DHA, and I will come back to all this human milk, probiotics, lactoferrin. They all have an effect on processes in the newborn infant, and they will reduce the neurodevelopmental, the chance to have reduced neurodevelopmental outcome. Well, until 1975, mother's own milk or donor milk, when that was available, were basically the only nutrition we had for the preterm infant. And I showed you the study of Lucas, where we used term milk for preterm infants. And it was until 1975 that we had preterm formulas. But also in that time, it was shown that infants fed mother's own milk had insufficient weight gain, lower than the intrauterine growth curves. And we then started studies all over the world, and we did as well, on the optimal nutrition of the preterm infant. So those studies are from 1975 and later. We should make a distinction between the needs for a very low birth weight infant, extremely low birth infant, very low birth weight infant, and the late preterm infant. And that is due to the difference in growth of those babies. The gain of weight, but that's not a good measure, but the gain of protein is the highest in the extremely low birth weight, slightly less in the very low birth weight, and much less in the late preterm infants. And that has implications for the feeding we give. And we all know this kind of growth curves, the intrauterine growth curve, and a baby from 24 weeks, 26 weeks, 28 weeks, they all have weight loss after birth, and they don't catch up completely. They all end up below the 10th percentile. And when we realized this growth curve, and we realized this was done by giving mother's own milk, quite often we started to give preterm formula, because we said with preterm formula, we can let them grow better. The question is, was that a good idea or not? With that, we have to look what the needs are of the preterm infant. Calories, protein, fat, carbohydrates, minerals, very important, and vitamins, D and K, all very important. But how do we know how much we have to give? So how do we define the optimal nutrition? Do we say, look at human milk, but mother's own milk growth was not optimal? Do we estimate or calculate the needs? And we did lots of studies calculating the needs of the preterm infant. We did calorimetry, and we did studies with amino acid solutions with isotopes. You're going to get growth. But growth, as I will show you later, when you express that the weight gain, that might well be fat, and we don't want to make the baby fat. Probably the best outcome is psychomotor development. But psychomotor development is influenced by so many factors that it is very difficult to find good nutrition by looking at the psychomotor development. That is not possible basically because of all the other diseases in the preterm infant. Nutrition is less important for outcome than, for instance, BPD. The risk for diseases in later life, and Professor Bos also talked about a healthy life, and now we see that when we don't give the balanced nutrition in the preterm infant, he might have a higher risk of hypertension, diabetes type 2, metabolic syndrome in later life. And finally, you can always say, when we have no studies, we have the expert opinion, but experts don't know everything either. When we look at protein, we know that with the food you take in your amino acids. Amino acids is taken up in plasma. Amino acids is going to body protein, so proteins are built, but at the same time, body protein is broken down to amino acids. So how much protein do we have to give to a preterm or anyone else? It is enough to compensate for the losses of the protein breakdown. And it should be enough to increase body protein. So protein requirements is body protein gain and compensation for losses in urine, skin, and the feces before absorption. And here you see the protein needs, and this is very important to realize this. Protein needs of an extremely low birth weight infant, a very low birth weight infant, and a late preterm infant. You see that the extremely low birth weight infant has a very high protein need, 4 grams per kilogram per day. It is slightly less in the very low birth weight. This is all due to a lower growth in these infants. The late preterm have even a lower growth rate and therefore a lower protein need. But you will see that the extremely low birth weight needs almost twice the protein intake of a late preterm infant. But please try to remember those numbers 4, 3.3, and 2.1, because I will come back to that later in my presentation. Carbohydrates. We all know that human milk contains lactose. But we now know that human milk also contains oligosaccharides, also sugars, but that are completely different sugars. They are not absorbed, but they reach the colon, and they are very important for gut flora. Oligosaccharides, also called prebiotics, improve the gut flora in the preterm infant. And gut flora is very important for the risk of infection and also for the brain. Lipids, well, lipids are a source of energy, but they are much more important. They are parts of the cell membrane, and they are gene regulators, especially DHA. What I showed is important before birth. During gestation is a gene regulator, and DHA and AA are present in fish and in few plants. But fats are much more than just a source of energy, and they're also gene regulators. Here you see a study in rats where they made rats PUFA, this fatty acid called PUFAs, polyunsaturated fatty acids, deficient. And you see that at birth, the deficient animals born from a deficient mother have a lower birth rate, but in the end, they have a higher weight. And they have, on average, a higher intake. So when the mother is deficient in these fatty acids, these polyunsaturated fatty acids, the offspring has a lower weight, but that's compensated by a higher intake, and finally they become fat animals. And this might happen also in humans, where as the mother has a low level of DHA, that will reduce birth weight, and in the end, they have a higher chance to have overweight. That's one of the reasons why PUFA during pregnancy is so important. This is a very important slide, because this is an old study by Kashyap and Bill Hurt in the United States. And they compared 3 feedings by bottle in preterm infants. Low calorie, 91, and 3 grams of protein. Then slightly higher calories and 3.6 grams, so higher protein. And the same protein, and then only higher calories. And what you can see is that when you give more protein in the body, more protein is laid down. And that's what we want for growth, protein accretion. So more protein intake gives you a higher protein accretion. But you also see that when you increase the calories from 100 to 137, you make them basically fat. Fat content almost doubled between the 100 and 137 kcals per kilo per day. So this slide shows 2 things. We can manipulate the body composition of the newborn infant with the feeding, and a high calorie feeding is giving more fat, while a low protein formula is basically getting a lower protein accretion, lower than what we like to see. Enteral feeding. Enteral feeding is very important for the preterm infant, because a number of the amino acids are used in the GI tract, and only a part reaches the bloodstream. So the enteral feeding is direct feeding for the GI tract, and the GI tract has to mature very much in a short period of time. So giving feeding is giving food to the GI tract, and thereby probably reducing the risk of necrotizing enterocolitis. Enteral feeding is also essential to prevent complications like infections and cholestasis. And there's a clear difference between Europe and the United States. When you hear a speaker from the United States, they will say, oh, don't give enteral feeding during the first week of life. And in Europe, we say, start enteral feeding on the first day of life. And that's because we believe in Europe that enteral feeding is doing a good thing to the newborn infant and is not risky. What can we give as enteral feeding? We can give own mother's milk. But we have seen already that by giving own mother's milk, the growth is not optimal as we like. So should we give a fortifier together with the milk? And when there's no own mother's milk, should we use donor milk? Or should we use donor milk with fortifier? Should we use a formula, a term formula? For sure not. It doesn't contain enough protein. And a preterm formula, that might be an escape when we don't have own mother milk. So the advantages of own mother milk for the preterm: positive effect on immunology, less neck, and less diseases in later life. But there are also disadvantages, and we should not forget that. Own mother's milk does not contain enough protein, calcium, phosphorus, very important, and it is an unstable composition. You don't know what is the protein content of mother's own milk. And here you see a study showing the composition of the preterm milk. And when you look at panel C, protein, you can see that the first 3 weeks, there is quite some protein in the milk of a preterm mother. But after 3 weeks, that is down to 2 grams. And when you give them 150 milliliters of this nutrition, you only give 3 grams of protein. Well, the need was 4 grams of protein. So you don't give enough protein to a very tiny infant when you give only mother's milk. Lactose is increasing, fat is increasing, energy is increasing, but the very important part of nutrition, protein, is decreasing. Here you see also the minerals, and the important is that when you look at calcium and phosphorus, I'll show you slides later, but the desired intake of calcium and phosphorus is around 100 milligrams per day, per kilo per day. And here you see you will never reach that with mother's own milk. Mother's own milk is absolutely deficient in calcium and phosphorus. And a study done in Airlangga University by Dr. Dina found that by giving mother's own milk, almost half of the infants did have osteopenia of prematurity. So here you see a study where they compared mother's own milk, HMF, human milk, and preterm milk. You see that weight gain is higher in the preterm, perhaps due to more fat. But length gain is almost also less, and head circumference is less in the preterm formula. So human milk from the preterm mother alone is insufficient for the preterm infant. I cannot stop with saying that the advantages of human milk are perhaps a little bit exaggerated. When you look at this overview of Miller in 2018, and I highlighted in yellow the most important things, that there's a very small reduction in incidence of neck, 2% reduction, 5% reduction in late onset sepsis, and insufficient evidence to draw any conclusion regarding neurodevelopment. Still, we should use human milk. Now, how to supplement human milk? That we have to supplement, I think, is clear. But the problem is that human milk is so variable from day to day, from mother to mother. And basically, you should measure the composition and then add and fortify. But that is clearly impossible. So there is one of the problems of the fortifier. Now the fortifiers, we all know, and I hope you all have them in Indonesia, It contains protein, carbohydrates, calcium, phosphorus, sodium, some vitamin D, but I think vitamin D has to give extra. And we should absolutely add a fortifier to the preterm formula, especially for infants below 32 weeks. When the mother has no milk, people have advised to give donor milk. But donor milk is the milk of a term mother, already lactating some time, and their protein content is really low in that milk. And studies have not found any real advantage of donor milk above preterm formula, because of donor milk contains very low levels of protein, calcium, phosphorus, and energy. Here you see the composition of donor milk that contains almost 1 gram, 1.2 grams of protein. When you give 150 milliliters, you only give 1.8 gram of protein, while we calculated the child needs 3 to 4 grams of protein. So it really is insufficient in the most important part of the nutrition, protein. There's the advantage of the preterm formula. It contains sufficient amounts of all nutrients. And hopefully now it will contain DHA, that polyunsaturated fatty acid, promoting neurodevelopment. The question is if the formula should contain pro and prebiotics. Probiotics are live bacteria, and prebiotics are the sugars that are present in human milk, the oligosaccharides. Well, still we don't know which bacteria to give and in which dose. Some products already contain probiotics. Lots of the products contain prebiotics, and prebiotics are those non-absorbed sugars. There, the risk of giving it is much lower, but probiotics are live bacteria. And there are reports that some infants develop sepsis based on the probiotics. So the optimal composition and the dosage of the probiotics is still unknown. So I would not advise to do that in Indonesia. Starting enteral nutrition. I think here, and that's the basic approach in the whole of Europe, start enteral nutrition on the first day of life, regardless basically on the condition. Nutrition is good for the GI tract, and it is very important for to build up enteral nutrition quite fast, and you don't have the risk of the parental nutrition. 20 milliliters a day start and increases 20 milliliters a day per kilo per day thereafter, either in 6 or 8 or 12 bolus or continuous. And we also give enteral feeding to sick, ventilated infants. And then increase it, and when you give mother's milk to 175, or when you don't have fortifiers, to 200 mils per kilo per day. And add, when available, calcium, phosphate, vitamin D, or a fortifier from day 7. With that enteral feeding, you don't give enough to the preterm infant in the first few days of life. And we want to prevent this decrease in weight. We have showed you before what was happening every day in our units. So we give now parental nutrition during the first few days. It's protein starting between 1 and 3.5 grams per kilo per day, lipids 1 to 2 grams, and glucose 4 to 6 milligrams per kilo per minute. So On the first few days, it will be a mixture, but the aim of your feeding schedule should be to be on full feeds at day 7 of life. Is it risky to start lipids? Basically not. And which lipid compound, the SMOF? Well, basically there are no studies showing that SMOF has real advantages. SMOF is increasing EPA, that's a precursor of DHA, but that might be dangerous for the preterm infant. So I would not use at this moment SMOF. To conclude, here you see the recommendations of the European Society Pediatric Gastroenterology and Nutrition in 2010. There's not a new one. Fluid between 135 and 200, so you can go up to 200 in a stable infant. Energy 110 in the more late preterm and 135 in the very small preterm. Protein 4 to 4.5 grams per kilogram per day in the very tiny infants. In the infants from 1 to 2 kilograms, 3.5, and above 2 kilograms, 2 to 2.5 to 3 grams. Lipids and carbohydrates. Conclusion: the optimal protein intake is dependent on gestational age. The lower the gestational age, the higher should your intake be. Weight gain is not a good measurement because weight gain is measuring fluid and lipids and is not measuring the protein. And a high caloric intake is related to an increase in fat content that may lead to overweight in later life. And positive effects on mitochondrial development are seen with administration of protein intake in the first week, in the first months, and after discharge. So protein is really the key of neonatal nutrition. And so nutrition should have enough protein, and the amount of calories should not be higher than 130 in the very tiny and 110 in the slightly bigger infants, because catch-up growth is not advisable. When you give catch-up growth, we have an increased risk of overweight in later life. Thank you very much.
Thank you, Professor, for your nice presentation. And now is the time for the, because there is still no question, maybe we can continue the panelist session. Maybe any other additional information from the panelists. Maybe first I give time for the Prof. Rinawati from Tito Mangkusuma. Maybe any other information, Prof? Please.
Okay.
That is yours.
Thank you very much for this opportunity, Dr. Martono, and also for the Faculty of Medicine Airlangga, especially for the head of department, Dr. Muhammad Faizi. Okay. Good evening, everybody in Jakarta and maybe in Indonesia, and also good afternoon for the speakers from the Netherlands. It is a very nice talk and very impressive. For me, the music therapy in NICU is really a new thing, especially when we talk about the live music in NICU. Yeah. What we have done here is the parents used to maybe ask the nurse to put the tape recorder, and sometimes they give like a Quran, maybe, you know, the Morutal Quran, just to set in near the babies. So if we heard here, there's something different with the live music compared to the recording. I found here actually, and then maybe I want to ask your comment, Professor Ari. I found live music was more beneficial when no touch was used, but recorded music is also good. But here was more effective when paired with some type of touch to the infant. Maybe you can give us some comment with your expert here. And then we still want to ask you, maybe here, I found in your study here, it was stated that the gestation of age, which is give more beneficial, is around 28 to 35 and not more than that. Is that right? So it is not used if we use the music for the bigger one or for the more tiny. And then how long that we should give, because here the parents or all of us sometimes give it even after nearly home. And then maybe we want to know as well how much decibel that the music should be played. Something like when you play a guitar, how much how loud the sound, that is, it should be like very low, or you can just sing, or you can just play the guitar maybe, or everything just as you want. Is it give any difference? And then we found that this is very good effect in the short term and then in the long term as well. Maybe that's, I think I want to give a point here. Maybe the idea is very good, but maybe we can, I don't know, maybe if we want to try for the live music, for our culture here, maybe, but maybe you can give us the comment about that. I stated for the recorded, is it really give also effective when baby is held by the parents, and then also something like touch, because I'm not sure that live music can be implemented right now in Indonesia maybe. And Dr. Martono, can I continue with the nutrition, or should just one by one?
Please, Prof. Rina, you can continue.
Okay, thank you. And then also Prof. Peter Sauer is very interesting as well when we talk about nutrition of the preborn infant. Yeah, I can say that nowadays more and more NICU in Indonesia may be already known, but of course it is not practiced 100% because of some obstacle. But most of us now realize that giving the proper nutrition for the preterm infant will give the very good impact, maybe for the long run, especially for the neurodevelopmental point of view. And then, as we know, maybe especially for the parenteral nutrition, there's still some difficulty for some NICU for the providing that the complete, as you talk about the protein, about the carbohydrate, about the lipid, and also about the regarding the access as well. Yeah, because all are related to the price that we have from our national insurance. But of course, that's a very important thing rather than talking about the parenteral only. You also mentioned about the enteral feeding. Yes, maybe this for me is very interesting talking about the donor here. Maybe you can share a little bit more about the donor. Because yeah, I can say that maybe we can start for the very preterm first rather than for the all babies who cannot the breast milk is not available. And then I know it is not easy to run that breast milk bank. So I would rather say breast milk bank. Maybe it's better to say like the breast milk storage in the every NICU, and then especially we providing for the preterm, so they can get a benefit from the donor. And then maybe I want to stress about the issue. Some babies, I don't know, is it because of the most of our pregnant mothers, especially for me in Jakarta, I think it also happens in Indonesia and in Surabaya as well. We found that the level of the vitamin D3 is very low. So almost 100% of our preterm baby have a dysbiosis. So what is the effect of that? We found that most of our preterm babies cannot tolerate that the preterm formula or yeah, preterm formula. But of course, if we have that breast milk, it's okay. But when we give the preterm formula, so that's the disaster. So the baby cannot weight gain, and then we can find that this bloody stool, not gross bloody stool, but just awkward blood, something like that. But it also the baby is not doing well. So we have to change maybe initially with the extensive hydrolyze. But the problem is this formula has a very low protein level. Do you have any experience with this? Maybe we can just change later on or something like that. Maybe I think that's all. Thank you maybe very much for your sharing.
Okay, thank you, Prof. Rina. Maybe first, Prof. Ari, you can answer. Maybe some comment for Prof. Rina.
Yes, thank you. A lot of questions. Well, first the question about live recorded or live performed or recorded music. Well, the studies so far, they have also seen sometimes positive effects of recorded music. One of the problems is when you play recorded music that you don't see if what the baby is doing, and the music therapy is trained to look at the baby while giving the music therapy. And our music therapy is based on lowering stress and distress levels of the baby, and the parents are stimulated to also to touch the baby, so they have a strong one of the other things that can help reduce stress and distress in babies is kangaroo care, so touch, and that I think it's also an important measure. So that is what it can be done. We still can entering in the next phase also recorded music, perhaps from the mother, where she can sing, and that's also the part of the song of kin, the music, the song, that's in the family, and it can be a hard rock song, it can be a Dutch song or a lullaby, whatever, and our music therapist transforms that into a song that is more lullaby-like, but that you can still recognize as the song of the family. And next, they also provide the parents with a CD or with an USB stick, so they can play it also to the infant when it's not on the intensive care anymore. And I think that's also might be helpful. So it can help with recorded music, but you should take care that you don't overstimulate the babies. We provide to all babies 24 weeks also, so not only to 28 weeks and onwards. We did that in our study as well, but we also found when it's not, it's published also, when we combine kangaroo care and care of and music therapy both, that might overstimulate in the first week. So we don't provide music therapy now in our first week. We think kangaroo mother care is very important. So if the mother is available and can be done, it already starts in the first day. Also in infants which are on the ventilator or which are 24 weeks. So with good precautions, we think that's very important. The question about how long we provided it, we give now 3 days a week. And not more than 15 minutes per session per day. So, and sometimes the infant is a little bit in distress. Right? The type of the music therapy is based on lowering the stress level. Yeah, you do other things when you want to lower pain, or then it's not by guitar song or by done by the guitar, but then you can, for example, when you want it, then you can provide it with the rhythm, with the gato box. But that's the expertise of the music therapist. It's now based especially on lowering stress levels. And when the infant is in distress, after 10 minutes or so, she stops. And the kind of music, it's not classical music or perhaps even not. It's just the song of the mother. And when they don't have provided it yet, we just it's simple in the repetition of simple and soft chords. There's also a question about how the decibels were, etc. We open the incubator and we play rather softly, so not more than 45-50 decibels. And we also have measured that with a decibel meter, that it's not more than that. That is actually, and it's very interesting that in some instances, that is also our experience, that when we provide the touch and recorded music, what Professor Rina mentioned, that might overstimulate. That might be in the first week what we saw as well. So we of course have a quite a low noise unit, because we already have for 15-20 years put a lot of efforts in making our unit as low with sound level as possible, and adapted our alarm limits, for example, and make the machines less noisy. So that is already quite not so noisy, but it's an interesting point that it should not be too high, and therefore also when she's playing, when you are 2-3 beds away, you don't hear so much from the music therapy. And then there was also a question in the chat about music during invasive procedures. Then you can put some other music. I'm not aware of any studies on that, but at this moment, our PhD student is now in New York investigating that. So during vena punctures and other blood sampling. She is. They are looking at an intervention and to see if that is helpful with this music intervention. So that's quite a world. I think I answered all questions. Yes. Finally, which type of music? It could be in Indonesia could be quite different than in others, and perhaps the parents already sing for their babies. That's also our experience with when we have parents that originally come from Curaçao, from a colony we had in the past in the West Indies. They are singing for their babies much more than the Dutch do. So it might also be a cultural difference already, that it's that singing is provided also to the very preterm babies. I think it's important, and I think also the mother's voice is important. And we have now new incubators where we can also perhaps integrate mother's voice and have the sound played off. But I would warn that you should take care of watching the infant then, and not just play it and go away. So you should take care that the infant is not overstimulated, because that is one of the disadvantages. I think.
Okay, thank you so much.
About the complexity.
Sorry.
Yes. Yeah, the complexity of the sound. It should be simple. That is. So please, I give the word back to Dr. Rina. Dr. Rina.
Okay, maybe the second is for the Prof. Sauer. Is there? I have some other addition of the question.
Yeah.
For the to set the Prof. Rina is there is one of your conclusion is catch-up growth is not visible. Does it mean the postnatal growth curve card should be refreshed, such as Benton? Maybe any other refresh for the growth, postnatal growth. Thank you. Is that the Prof. Rina question?
The problem in Dr. Matono, I have little problem in hearing you, but I hope I do right when I now answer the questions of Dr. Rinawati. First, Professor Rinawati.
Okay, maybe you answer the Prof. Rina first.
Well, Professor Rinawati asked about donor milk, and well, I think now in the world of the nutrition, our concern is protein. And the problem with donor milk is that the protein content in donor milk is quite low, because it is a term mother who already delivered some time before. So by giving donor milk, you hardly give, or you will not give enough protein, neither calcium or phosphorus. And so then you have to add quite some fortifiers, but then you have to measure what the content is. Secondly, there are basically, when you look at all the studies comparing donor milk and preterm formula, and there are Cochrane studies done, they do not show a benefit of donor milk. And I know there was a study also done in Groningen, where also I think, and I can comment, there was no real advantage of the donor milk. So nutritionally, it is not a very good idea to give donor milk. Now, yeah, I do not know why infants in your unit have problem in tolerating a preterm formula. It is not my experience, so I have no clue why that should be. To give an elementary feeding to a preterm infant is not a good idea. That composition is not made for very preterm infants. So that is not the proper nutrition basically to give to a very preterm infant. So now I have no clue why in your unit the infants do not tolerate a preterm formula. And then I can understand when you have that problem, that you want to go to donor milk. With donor milk, when it is frozen, your immunoglobulins are destroyed. Now you could say that's not a real problem because the immunoglobulins of that donor mother are not against the bacteria the child received from the own mother. So the immunoglobulins of the donor is not really suited for the preterm infant, because the preterm infant needs immunoglobulins against the bacteria the child received from the own mother before birth and during birth. Then about vitamin D. Well, I have a little hesitation in answering that question, because clearly Indonesia has enough sunshine to produce vitamin D. But we all know that vitamin D is mainly produced in the skin of the head. And when you are all dressed up in dark clothes, I'm afraid that might be a reason why Indonesian mothers have low vitamin D level. They stay at home, they don't sit in the sun, and when they go out, they're all covered up. And therefore, that's my most likely explanation, that is the reason they have low vitamin D levels. It would be interesting to do a study. I always want to answer a question with a study, because that's the only solution, to measure 20 mothers who have very religious approach regarding their clothes, and 20 mothers who have a more non-Muslim approach, and then see what's the vitamin D level in both groups. I think I answered the questions.
Yeah, thank you.
The study. Sorry.
Yeah,
sorry. I want to add to the study on the donor milk we had here in the Netherlands. It was 10 days in the very young infants for the first 10 days with donor milk or not, and the first outcome measure was incidence of necrotizing enterocolitis. There was no difference, and the immunoglobulins it could be because we pasteurize it, so it's some of the good components of the milk are destroyed. So that might be one of the reasons, and there's still follow-up measure where some things might be favorable, yes or no, but that's for later.
Oh, but the Cochrane reviews for now do not show any positive effect.
Agreed.
Okay.
Okay, thank
you. Because some of our even the Minister of Health now encourage us to have like the not donor milk bank in the national donor milk bank, but every single hospital encouraging to have that one. But maybe having hearing your talk, maybe we have to think later on about that.
Well,
Thank you, Prof. Peter Sauer.
My answer, I would never make a national milking bank. That I would never do. I would prefer a hospital-based where you have full control about the whole procedure of collecting the milk, freezing the milk, storing the milk. That is so touchy. It needs so much attention. You can do it better in your own hospital.
Okay, thank you.
Okay, thank you, Prof. Sauer and Prof. Ari and Prof. Rina. There is still one question in the chat. is from Dr. Setiawan Dita. One for the fourth hour, they said that one of your conclusion is catch-up growth is not visible. Does it mean that postnatal growth curve chart should be revised, such as the Fenton? Maybe you can answer, Prof. Sauer.
Sorry, I could not very well hear your question. Ari, did you hear?
In the chat, maybe in the chat.
So the catch-up growth is not advisable. Does it mean that the growth curve charts, Peter, should be revised?
Okay, thank you. No, now we know that most infants grow below the growth curves. And when I was still very practicing neonatologist, we thought we have to give them catch-up growth. But now studies have clearly shown that when you give catch-up growth, the chance to have obesity in later life has increased. So what we now advise is try to prevent weight loss after birth by giving fast enteral and parenteral nutrition in the first week of life. Try to prevent weight loss and increase enteral feeding rapidly. So try to prevent this drop, and then don't try to let them go faster than the growth curves. The growth curves are okay, but they should not grow faster than the growth curves.
Okay, thank you, Prof. Sauer. Next is maybe any additional information from the panelists? Maybe Dr. Setia Dewi Lisyati or Dr. Risa Etika.
Yeah. Thank you, Dr. Martono, for the opportunity and invitation to be here. I'm very happy and I enjoy very much to hear the presentations. That's very excellent, I think, from Professor Sauer and Professor Ari both talks, and allow me to give little questions to both Brother Martono. And first to Ari, and this is a very amazing result and finding from the study on the music therapy. And from this study, I conclude that the music can give a less pain, more comfort, and improve heart rate, respiratory rate, and feeding intake. And also the good news is can change the nurse's behavior. So that is a very, very good news, I think. So you mentioned specifically that live perform is better than recording music. I would like to know further about the music itself. So first, how can you get to this idea about that the live perform music is better? And how could you find out that there should be, you mentioned specifically certified neonatal music therapy, and then what is the requirement to get certified neonatal music therapy? Is it a must to run a music therapy? Because then, yeah, like also from Dr. Rina mentioned here, the parents or nurses often put the tape recording from classic music or Al-Quran, something like that. And I don't know if also compared to the classic music, I think you must study about this kind of the music. Why then what is the story? Why then did you choose or decide the kind of the typical of music for the music therapy in those part? And then second, this about your study. In your presentation, you mentioned in a music therapy study, if I am not mistaken, there were two preterm infants 32 weekers with a different response after music therapy when you did crossover study, and the response is different compared to the other preterm infants. I mean the response of the general movement score. And then what is the reason behind why is it different? Do you study it further for the condition, for the medical condition? Perhaps there was a problem with the hearing function or something like that. And then also during music therapy, is there any specific position of the infants? The patient should be in a supine or prone position, because when they do kangaroo, so the patient in a prone position. So for the music, it should be a supine or prone, because the response will be different regarding the position. And can I continue to Peter, Dr. Martono?
Okay, you can continue.
Thank you. Thank you, Peter, for very, I think it's very impressive and fruitful talks. You talk start from the past, start with the history from the past until today, and also that's very basic. So I think each of us can reflect our practice where we are today. If we were in 1975 or in the 1980 or 20s or like now. Yeah, I think it's very nice to hear. Allow me to ask you two questions. You know, in Indonesia, there is a large proportion of small gestational age of the preterm infants, or in other words, infants with growth restriction, fetal growth restriction. So my question then, how, as also you just mentioned, to prevent the obesity, something like that. So I am very happy to hear about this. But then, could you advise us how fast the optimal growth velocity in those groups, in those fetal growth restriction patients, to prevent such a metabolic disease when they are adult? This is the first. And second, I also remember in the past, we in Harapan Kita and perhaps also in other hospitals, also in other countries as well. Also, sometimes we give like corn oil to promote growth. But then I remember at the time from Prof. Ari remind me that should be careful in patient with a BPD, because then can produce a more CO2. So then my question, to promote brain growth, also adding the long chain polyunsaturated fatty acid, especially in preterm infants with fetal growth restriction. Is there a good idea if we add olive oil into the feeding. Yeah, this is my application. Thank you, Dr. Martono.
Okay, thank you. Maybe first, Prof. Ari, you can answer.
Yes, the question if it's is live music versus the recorded music. Well, the live music has the advantage that music therapist can watch it, and what is required that she can watch the infants. And as we sit here, at least I was always told to, and I also teach it to the nurses, that they don't look at the monitor and look at the heart rate, but they do have to look at the baby. The music therapist is looking a lot to the monitor and see what's the reactions of the baby, and about heart rate and respiratory rate. And she looks also to the child, to the reactions. And that's the training of the music therapist is a general training. It can also be, music therapy can also be applied in psychiatry and in geriatry for people who are have dementia. It is for in ADHD for the younger the boys and the girls that are in their teenage years or at school age still. It's a very broad training, a very broad education for 4 years, a music therapist. And then there's a special NICU therapist session where that takes 1 or 2 weeks, which you can do, and which our NICU person also has done. So you can play recorded music, and in studies sometimes it works, but sometimes in other studies it is even detrimental. And then when you look at least at or you don't see anything, and that's also our experience when you, and it's also when we play music, and sometimes you're not in the mood for music, and then you can turn it off, but the baby doesn't have the chance to turn it off. He can also only react with distress when he doesn't like recorded music at that time. He can like it 1 hour later or 1 hour earlier. And I think and involving the parents might be a very important effect of this, that you can say, okay, which song is your family song? And then we make that a song of kin and we provide it to the baby. And he already knows it for 24, 27, 28 weeks because he had heard it before. That hearing is developed around 20 weeks, baby can hear, perhaps already at 18 weeks pregnancy, the fetus. So that's one of the answers on that question. The question about the music therapy, the 2 infants that had a different response. Yes, of course, we looked at the medical conditions and so, but we could not find it. And so that's always research. Sometimes you can find that the reactions are different. So we don't know yet. And of course, we have much more data we still have to analyze on the effects of music therapy, also lab results about methylation, DNA methylation, for example, of stress-related genes in these babies. And we are just doing that still, and we have to also look at the long-term outcomes. The position of the baby, it doesn't matter. When the baby is in supine position or prone position, it can be provided with the music therapy. In the music therapist opens the doors, it plays softly and slowly with the guitar and sings with the baby. And parents are also stimulated to sing if they like. And that's how it is done. And when they are when we provide it while they are in kangaroo mother care, we say always it should be at least 1 hour. So the mother has or the father has it in his lab for that time, and then the music therapy is added for 10-15 minutes, and still we watch how it is done. So you can provide music therapy also with recorded music or with the song of the mother, but the warning is take care of overstimulation of the baby, because that is the reason why some studies looking at recorded music did not find any effects or even adverse effects.
Ari, okay. Can you define what the means of the overstimulation by the music? Is there any specific definition?
Now you can see it on the heart rate. Infants getting restless, making more avoidance behavior. So that is, and for example, when you look at the Neo Comfort Score, and we did that, and when our music therapist sees the infant is not reacting quite well, she adapts what she offers in the music. It's not just playing. Now then she lowers the tempo, or she is more quiet, or she makes another rhythm, whatever. So that's her training. That's why she is doing that, and that's not being done with the taped music, with recorded music. And it's really a new development. It's more done in the United States at the present, not so much in Europe. We are the only and the first one, but still the only one who's doing that in the Netherlands. It might be that there are many that are interested in how to perform it, and also want to start with, and it might be that it is more, but I think the most effects are also on that you give the parents the idea they can do something for their baby. They are not powerless. They are not that they are just feeling guilty, or that there's something they can do for their baby. So it's really a teamwork between nurses, doctors, and parents.
And one thing, before you mentioned, you correlate with the near-infrared spectroscopy, and then you mentioned that the pattern during music therapy then decrease little. Yeah, is it correct?
Yeah, in half day it increased, and in half it decreased. So, and we have to think, how can that be? It is a balance. So when it increased, it might be that the blood flow to the brain is getting better. When it decreases, it might be that the blood flow is getting less to the brain, but it also might be that the infant is a little bit sedated and uses less oxygen in his brain. That's then it rises, or it is perhaps overstimulated, then it goes down. It's always a balance to what is delivered to the brain and oxygen, and what is used by the brain. So because the saturation in tissue is more or less the venous saturation. Yeah, so when the brain uses more, it drops. When the brain uses less, it goes up, the saturation. When the supply is more, then it goes up, and when the supply is less, it goes down. So this balance we don't know yet. There's more studies has been done, but it was striking that there is actually two patterns. Half of them go up, half of them go down. It's not so that some remain the same. Mostly, so it's very interesting to look at how that comes. And we know that both high oxygen, that's not good for your cognition, and low oxygen in the brain, that's not good for your motor development, is a poor sign. So being in the middle might be good.
Yes. Yeah. Okay. So still no conclusion yet.
No conclusion about the NIRS yet. There has to be more research being done there. It's very interesting, but it's not known yet.
Yes. Okay. Thank you. Thank you.
Well,
Okay, Prof. Sabar, please.
Dr. Lucy, thank you very much for your questions. Always from Dr. Lucy, I get very good and very difficult questions. Now, the intrauterine growth retarded baby, what is that child missing? Is the child missing protein, or is the child missing lipids, fat, or is the child missing fluid? And I think the most important here is the protein. So we don't think we should let the child grow fast, give it anyhow enough protein to pick up for the protein deficiency they have. So I would once again give a high protein intake, not with so many calories, because then you might stimulate lipogenesis and that lipogenesis might stay on for a long period of time. So it is not to give the child, to let the child grow. The child grows, misses probably protein, calcium, phosphorus. That are three things that he might miss, she might miss. So you have to give those insufficient amounts, not only protein, but also calcium and phosphorus. And I know that phosphorus, you usually don't use phosphorus solutions, but phosphorus is a very important component of our body for energy processes. So take care of calcium, phosphorus, and protein. And don't give enough so much calories. Be restrictive with calories. Because that is what the child is needing. Then your second question.
Olive oil.
Olive oil. Well, that is basically the same answer. Why to give extra oil? What do we want to achieve with giving extra oil? Weight gain, but then the weight gain is fat. So a low weight gain, and I have a slide but I didn't show it, low weight gain can be due to low protein intake, a low calcium intake, a low phosphorus intake, and low calorie intake. But be a bit skinny is not a danger. So I'm not so worried when they are going on the underside. As long as there's growth, then I'm fine. And then I would increase protein first. I would increase calcium. I would increase phosphorus. Measure in urine the calcium and phosphorus output, because that is very important. When you don't have phosphorus, you don't go either. So don't give olive oil. I think that I did in the past as well. We give extra carbohydrates, extra lipids to grow. But that is not what we do today, because that is not what you want to achieve. You want to achieve real growth, that's protein.
Even in the olive oil, there is a high content of the omega-3.
No. Olive oil has not a high content of omega-3 fatty acids. And what you need is omega-3 fatty acids. And that's not olive oil.
Okay, yeah.
That's either fish oil or seeds, what's it called?
Algae seeds.
Sorry?
Algae seeds, van algae?
Yeah, algae and rapeseed, koolzaad. No. The omega-3 fatty acids are in fish, so fish oil, but fish oil, like I said, has also EPA, and EPA might not be a good idea for the preterm infant. So they make pure omega-3 DHA with algae, or give a precursor, but to be careful with the EPA. Fish oil basically is precursor. Rapeseed oil. Yeah.
Yeah, and how about the growth for those groups, preterm with IUGR history? Should they follow their own curve during intrauterine, or then better to get or to achieve the growth perhaps after 1 year old, same to the gestation, other patient with the same gestation, but without growth restriction history?
Yeah. Well, we know that a child with intrauterine growth restriction might end up smaller, shorter, less fat than an average child. And we now tend to accept that. We accept that they stay some smaller. Studies have looked at the use of growth hormone in these infants. You can stimulate growth with growth hormones, but I don't think you should try to stimulate growth with nutrition. Whenever you want to stimulate, when the child is really small, really below the 3rd percentile, studies have used growth hormone to stimulate growth. But that is better than stimulate with calories.
Okay,
yeah.
Thank you. Yeah,
Okay.
that's all.
Thank you.
Dr. Martono.
Okay, thank you, Dr. Yusi. And the last is for the panelists. Maybe Dr. Risa Etika have some additional information.
Thank you very much, Dr. Martono. Good evening for our dear colleagues in Indonesia and our honorable panelists, Dr. Lucy and Professor Rinawati, also our Honorable Chief of Health Department Sutomo Hospital, Dr. Faisi, and also good afternoon for our Honorable Speaker, Professor Ari Bos and Professor Peter Sawers. It is great to see so many of you in this webinar. Thank you for Professor Lim from Nijmegen attending this webinar. Then I would like to thanks for the both of you, Prof. Ari Bos and Prof. Peter Sauer. We know both of you well as a adjunct of professor in Universitas Airlangga. I would like to thanks also to Dr. Lucy from Harapan Kita Hospital that give us guide to send my staff in our unit neonatology division sent to UMCG for training internship, namely Dr. Dina Anggelika, neonatologist, and Dr. Kartika Dharmahandayani, neonatologist. And also one staff member are studied PhD there, namely Dr. Mahendra, PhD. It is such a honor for me to be a panelist. So I have one question for Professor Ari Bos. I would like to ask about the effect of music therapy if we give to the preterm infant about the decibel. How safely it's decibel in the NICU. Thank you, Prof. Ari. And then I continue. I would like to ask to Professor Peter Sauer also one question. Do you recommend it about the preterm nutrition such as additional of probiotic multivitamin and ferrum to prevent deficiency ferrum. Thank you.
Okay, thank you, Dr. Risa. Maybe first, Prof. Ari, please.
Yeah, thank you. It's a very good question, of course. I thank you for the nice words, Dr. Risa. The effect of music therapy to give on preterm infants with the decibels. Yeah, that's also what we wanted, and we also put a sound meter into the incubators when we started with this, and the amount of decibels, it did not it was more than around 45 to 50 decibels. I think when you provide CPAP, bubble CPAP, it's sometimes reported that it might even be 60 or 70 decibels, so quite a loud noise. And we also wondered, because it was a question of our reviewers, do you see different effects on, for example, infants on CPAP or not? And the most effects we saw was on the infants without CPAP. So that's a very interesting questions about the decibels. So that's also a point of future studies on the sound level in the NICU and also by the music therapy. But it played very softly, and it's also in the environment of the baby that we are measuring what we are doing.
Okay, and the next for the Professor, please.
Yeah, thank you. And I follow up of the question of Professor Bos. I can assure you that in the modern neonatal units, the sound noise is quite low. It is not anymore like when we started, beep, 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 beep all the way. Now it is really much more attention, also in the building, to have a quiet environment and not a noisy environment. And the incubators itself became also much more quiet. In the past, we had incubators, they were making 60 to 70 decibels. So the baby was exposed to continuous noise. But now with new apparatus, that is much less. When I understood your question, well, iron. Well, the issue with iron is that when the child is growing, his amount of red cells has to increase. So he has to be able to make a lot of red cells. And therefore, it's important to give iron. Anemia of the prematurity was well known in the past. That was probably due to taking much blood for the laboratory. Now we have micro methods. So with one drop of blood, you can basically measure everything. And thereby is the use of blood transfusions has decreased tremendously. But what can help to diminish further the blood transfusion is to give iron. So that's why I said it's also important to give iron to prevent blood transfusions.
Thank you very much.
Thank you.
Prof. Ari and Prof. Peter Sauer. Thank you, Dr. Martono.
Okay, thank you. And after the Dr. Risa question and the answer from the Prof. Ari and Prof. Sauer, that's all for today. So we can conclude that live perform music therapy may present a promising intervention in the neonatal invasive care. Evidence suggests that music therapy improves physiological status, motor abnormality, indicated by GMOS, brain oxygenation, and decreased maternal anxiety. Music therapy is also received very positive response from the infant parent, and safety assessment show that infant manifests no changes in the overstimulation indicate based their stress score. For nutrition, the nutrition profit a short and long-term good impact of the preterm infant. Nutrition mediates the better growth velocity and neurodevelopmental balance macronutrient, micronutrient, fluid necessary to optimize the quality of preterm infant. Now, thank you for the all panelists and participants. It's a question, but I'm sorry because there is a running out of time. We hope we can discuss again later. Hopefully, we can do meeting again with our Chancellor Professor in next opportunity. Thank you for Prof. Ari, Prof. Sauber, and the panelists, Prof. Rinawati, Dr. Lucy, and Dr. Risa. Thank you.
Thank you, Dr. Martono.
Okay.
Thank you.
Thank you.
Terima kasih, Dr. Lucia. Thank you all.
Terima kasih.
Thank you.
Prof.
Terima kasih.
Terima kasih.
Thank you for inviting us.
Profesor Pos, Profesor Sauer, Prof. Rina.
Okay.
Terima
Thank
kasih.
you.
Thank you,
Thank you
Prof.
all.
Sauer, Prof. Ari,
Matur nuwun.
Sami-sami.
Terima
Atas semua partisipan dan tim AWCS yang sudah membantu acara ini berjalan dengan lancar.
Terima kasih. Izin live.
Pak Iding, makasih Pak Iding.
Sama-sama, nih. Maaf nih,
Assalamualaikum.
baru
Matur
di
nuwun.
luar.
Iya, Mbak
Nih,
Terus, saya.
sami-sami.
When they are